For those of you who might be new to this, this is the Equip Thursday Family Support Group. I am JD, the Director of Lived Experience here at Equip, and I have a couple of our frequent guests with me today, and I'll let them introduce themselves. Just some logistical things. If you would like to speak either on camera or just through the microphone, you can wave your little Zoom hand, and we will give you permission to do that. You can type questions in the Q&A. You can type them in the chat. However you want to show up, we would love to have you here. And as always, the advice we give is very general, sort of not really specific. We're not anyone's treatment team, but we think that we have a lot of collective wisdom here. And a lot of times you'll see other folks weighing in on the chat too with a lot of wisdom. I'm actually gonna call out Sue, who frequently is dropping links in there, and let her know how much I appreciate her as just somebody who comes to the group. So Maris, why don't you introduce yourself?
Sure. My name is Maris. My pronouns are she, her. I'm the Director of Peer Mentorship here at Equip, and I'm someone in recovery from anorexia nervosa myself. I was diagnosed as a young teenager, was able to access treatment and support very quickly and with the support of my family. So I'm always happy to answer questions about peer mentorship, about my own lived experience, whatever would be helpful.
And Shira.
Hi, I'm Shira. I use she, her pronouns. I'm a dietitian and just love getting to support families through the very difficult but worth it journey of treatment and recovery.
And I think it's important too, Shira, that you worked at a lot of different levels of care. So I think that's really great. I found you able to answer a lot of questions that are maybe not things I had experience with. So whatever folks want to talk about, you can just jump. We're just doing Q&A today. We do have some themes coming up next week. We're going to have Kevin Olmsted, who is the author of Brave Dad Feeding on. We're going to have a really amazing presentation with some of our folks who are deaf, hard of hearing, and working on getting an interpreter for that. So really excited about that. We have a question a little bit later. I think it's about 3 weeks from now on the what ifs of treatment that we're really, really excited about. So lots of stuff coming up. While we wait for questions to come in, I'm just going to take some from the submissions of what people have been asking. Let's see. Actually, Maris, there's a question. Can I ever get free from my eating disorder? Pretty big, broad question, but.
Yeah. I feel like that's the $1 million question, right? And so many patients that come to treatment or start treatment at Equip or elsewhere basically have that question of like, am I putting in all this effort for nothing? Or am I going to be able to find a time in my life where I think less about my body, I think less about food, maybe I don't even think about it at all. And, it's always important, I think, to recognize my privilege and positionality in the discussion. I got diagnosed very quickly. We could afford treatment. My parents could take time off work to support me. So I just want to acknowledge that this journey will look different for everyone, depending on where you are and what resources you have access to. But I think there always is this North Star that we know that recovery is possible, even if it looks different for everyone. So I can say from my lived experience, if I were able to kind of time travel back in time and talk to my 14-year-old self, I would not believe any of this. But I'm in a place now where I really don't think that much about my body. Food is something that feels fun. I feel able to really be present with the people around me and not have that burden, that experience. So it is very possible. And people have slightly different definitions of recovery and experiences of recovery. So all those stories are very important there as well, but definitely possible. I don't know what you both would add to that.
Well, I just was, it pinged for me when you said I can be present, and I'll send out the recording. My daughter and I did a podcast with Christina Saffron, one of our co-founders for Recovery Warriors, and she used the word present several times. And I don't know that I had heard her say it that way before. And that was really touching, that ability to be present in the life you're living now and not sort of have this other allegiance that comes before everything else. I certainly believe full recovery is possible for people who want full recovery. I'm with Maris that there's lots of other factors that can go into that. I've just come off a whole day of listening to the BIPOC eating disorder conference and really mindful of a lot of the things that they had to say about various systems and things like that, and how that can impact recovery. Also demographically and economically blessed here, and so that leads to quicker intervention, that sort of thing. And also, I've known lots of people from all demographics and ages who have struggled with an eating disorder for 10, 15, 20, 30 years and have gotten to what they will say is fully recovered. Your experiences, Shira?
Yeah, I think, Maris, you mentioned this, that idea of like everyone's recovery and what recovery is going to look different. And I think that's a piece to really be thinking about when thinking of that idea of like full recovery, because you can be in your version of full recovery, which might not be the same for somebody else. So just not putting any kind of judgments on what recovery looks like.
And I want to say, if you really want to be sort of like fully in recovery in the way Maris described, to enjoy food, be present, not have, worries about exercise, not overly concerned with body image and things like that. I think that's a thing that you can choose to pursue. And it just sort of made me think of, I'm almost 6 years old. And so when I have something happen to me, you're always like, oh, is this the time my knee never works right again? But I have a friend who's a physical therapist who said, every time you have something, you go to the doctor, you tell them, I want everything back. Like she said, when people get to be your age, the physical therapist or the orthopedist are like, like 90% is good enough for someone that age. And she said, and that's not what you want, because you like to hike and all these other things. So just make sure you ask them for what you want, which is to get all the way back to where you were. And that was really good advice. After dismissal from IOP, how often should a client see a therapist or dietitian per week? We're sort of going to give this as a general answer. And if you want to pop any more information in there, we'll wrap that in. What are your recommendations for folks, Shira?
I'll start with my token answer. That's not an answer, of that it depends. Because there just really are so many variables of where your kiddos or loved ones at the end of IOP. It's a big transition, though. You're going from typically, at least 4 days of support to then not as much, no days of support in that same way. So I think a lot of programs will recommend weekly follow-up. I know I'm just from thinking of my own experience in working at different or at a treatment center, that piece of you finally are like, oh, we've made it to the end of IOP, we get some more freedom and our life back, that then thinking about a once a week appointment with a therapist and a dietitian feels like a big ask still. So sometimes it can be alternating every other week, just really depends. You just don't want to totally cut ties with your main treatment team and supporters.
Yeah, that makes a lot of sense. I think that depends is very important, right? Because some people buzz through all the stages because the insurance company is breathing down their neck. Some people are able to kind of go as long as they want. That's a more unusual situation. So I think more than where are you in leaving a program, I think probably it's really where are you in your recovery and how much support do you need to maintain that? What are your thoughts, Maris, on that?
Yeah, I just could co-sign everything that's just been said. It's so individual. It just really depends on where you are in your experience. So yeah, nothing more I can add.
I will say that I put in a plug for the continued monitoring. And I think that particularly transition times are always very hard. So it can be nice to be established, get established with people. And then if you don't need to go all the time, and virtual makes this easier, right? You're not going as often, but then they're there if something happens and you need to boost up treatment. But a lot of support on transitions. And I'm a huge one for sort of setting your mind to not going backwards from where you are. You fought very hard as a person, as a caregiver, someone to get where you are. So I think sometimes there's a little bit of acceptance that, after IOP, you'll go backwards a little. And I'm like, let's try not to, because you worked really hard to get here. My daughter's 21 and struggling with anorexia. She's just graduated from college and has a BMI at 15.4. She's not had any form of treatment yet. A lot of the programs I am looking into are recommending residential, but she is looking to get better and is willing to accept help. Do you think a virtual program could be enough? I'm glad that she's willing to get help. And I actually I don't fully know what our cutoffs are. I will say one thing that you might struggle with at that BMI, and you probably better equipped to handle that piece of it, sure, could be not qualifying for some programs due to low BMI and then wanting medical monitoring in place really robustly to get that up. What do you think, Shira?
Yeah, I think the medical stability piece could be where some recommendations are coming from there. Again, obviously we don't have all of the information. So meeting residential or having that be a recommendation doesn't mean that your loved one does not want to get better. I think I'm now going to use what JD always says, residential is a place that you go to work to start treatment or to be in treatment. It's not a treatment modality. It can be just one piece of the puzzle. So I guess if your daughter's feeling like residential means I don't want to get better, like really challenging that, because that's not the case, that you can do a lot of really hard work in residential with a boatload of support, especially for someone who's 21.
Any thoughts, Maris?
Yeah, I it's so hard to speak to this individual experience. Maybe I can talk just more broadly about, I think a lot of families toy with that question of, is virtual enough? Is it effective? And as you both mentioned, Shira and JD, like that medical stability piece is something that needs to be attended to and really taken into consideration there. For folks who, are medically stable, being able to do care in your own home can actually be really beneficial for a lot of families, because you are in your day-to-day life and you are practicing facing the triggers that you face at home and in your daily activities, and you can stay connected to things like friends or other community networks of support. So there's so many different paths there, and it can be really helpful to just explore all of your options, meet with providers that you trust, help inform that decision as well.
Yeah, thanks for adding that, Maris. To the bigger picture, we frequently have people who come from a hospital stay straight to us and do very, very well. So I think it's really great that we have more options now, particularly for someone who is that ill. And some people will choose to work really closely with a medical provider and have labs frequently and maybe get their weight at home with the help of their family and that kind of thing, and then be able to access some more varieties of help. And that actually feeds into the next question pretty well, which is, what is an interdisciplinary team support like with your program, and what does it include? And not an equip infomercial, and you asked, so we're going to tell you. With the equip program, every family is getting a therapist who serves as a case manager, a registered dietitian, a medical doctor, psychiatric nurse practitioner, or psychiatrist if needed as well, a family mentor, and a peer mentor. And the way all of those work sometimes can vary a little bit depending on age, but basically you have all of these people wrapped around who have expertise in different areas to support and guide you, and who also work very closely as a team. And so that's one of the things that people will say that they appreciate about us. You can have a dietitian, you can have a therapist, you can have a doctor, and the reality of the world sort of outside equip is pretty hard for all those people to communicate about all their patients every week. It's a lot. So generally it's not a thing that happens. So one of the things people really like is that we generally are speaking with one voice. So if we are if there's different ways something could be handled, we'll talk about that and talk about who needs to be talked to, and then we'll present it sort of as all at once. That keeps from being like, oh, I thought I was supposed to do this. No, I thought I was supposed to do that. So I think that's really helpful. We also have groups, a wide variety of groups, both for our patients, for family members. And we also have, and one of the most exciting things is we have a body image intervention program called Freeform that's accessible to both families and patients at certain times in their treatment when that's indicated. And that is really, really helpful, because a lot of the times there's just not enough time to get to the body image stuff, because you've got to be really pretty well for that to work. So that program is really exciting and a lot of evidence behind it. what would the two of you add to how we do things at Equip?
I can say more about peer mentorship just because I'm excited about it. But it's something that I really love and appreciate about Equip and feel like would have really benefited me in my own recovery was in the beginning, to go back to the first question we answered today, I really was not convinced that recovery was worth it. I didn't know anybody that shared that they were in recovery from an eating disorder. I didn't have people that I could go to and ask kind of the more shame-inducing or embarrassing or, kind of those more hidden parts of recovery questions too. So we have a peer mentor for that reason of having that one-to-one safe space for patients to ask questions, hear stories, and then also just have even sometimes a place to talk about anything other than eating disorders for 30 minutes and just talk about hobbies or interests or things that you want to get back to. So I love that piece that we have here at Equip. We also have family mentors that balance that for our supporters and caregivers. That always excited to talk about peer mentorship.
And Shira, from your perspective as a clinician, working in this type of environment, what would you say about that?
It's amazing. The mentor piece of the program is just so, I'm going to say amazing again. I can't think of another word. And, from all of my experience, I often found myself trying to play all those different roles, and it's not as effective. I do feel like I bring a lot of experience of working with parents, but I also have not been the carer of somebody who's my own loved one. Yes, I've cared about all of the patients that I've worked with in residential, but it's not the same. And I can't provide the same perspective that a parent that has gone through it can. So I love not having to feel like I carry all of those burdens, that it can be something that comes up and we touch on it, and then it can be that's a great thing to talk about with your family mentor, or encouraging parents to have their kiddo talk with the peer mentor about how they navigated that, or tips and tricks. So it's just I'll just round out for 3 for 3, amazing part of the program and great to work with.
And the other thing I wanted to add to that is we have so much training. We have a lot of training as folks come into this, and then we have weekly training with CE credit, continuing education credit, and it's just the coolest thing that every single Thursday we're learning really amazing things from leaders in different fields and things like that. Thank you, Sue, for your input. We love our family and peer mentors. They've been key. Lived experience has been priceless. We agree with you, and we thank you. This is a really good question. How do you treat ARFID ARFID differently from anorexia in a virtual program? I think that's what the question is. It's not quite that. It's the way it's written, I'm not quite sure. So you can clarify if you want. But differences in treating ARFID and anorexia, Shira, this is definitely your wheelhouse.
Yeah. So part of me wants to say very differently, and part of me wants to say not very differently. So it really can depend on how that ARFID presents for your loved one. With anorexia, there's a little bit more of it's just sort of here's what we're doing. We know there's fear from the eating disorder around wanting to eat this, and yet we used to eat all these different foods. Whereas with ARFID, there's just a lot more nuance to it for everyone. And I'm not saying with anorexia there's not nuance to it, because there is for every single person. Everyone's unique and it presents differently. I feel with ARFID, there's just can be quite a bit more collaboration between the family, the parents or caregivers, and the patient who's going through it, of where are they at with wanting to try new foods. There's less of a push to introduce new foods. If someone's needing to restore weight, it's here's the foods that we know are comfortable and safe, and let's focus on that. Let's work on helping them feel more comfortable, helping them feel that there's not as much pressure to eat, which can often feel really the opposite of with someone for anorexia, where we sometimes are when they kind of feel that pressure, that's where some of that change can come from. Whereas someone for ARFID, that can be the exact opposite. So those are some of the things that kind of stick out for me around differences. I think the not pushing food and variety is probably one of the biggest ones initially when someone's needing to restore weight, that we're like, let's stick with what they're comfortable with and use those.
I think one thing that happens also in a lot of support spaces and things like this is that people are unaware that very often ARFID also needs that weight gain component for that enhanced cognitive flexibility, that very often growth curves have been suppressed, things like that. And just also in general, we have a really robust ARFID program. I think about a third of what we do is ARFID patients, and we employ some folks who built a really amazing ARFID program previously. So happy that we can offer this ARFID. We've had family mentors with ARFID. I always tell people, I often do a lot of calls with people who have more questions when they're admitting. One of the things when people have kids who are younger, they're like, how could that peer mentor thing work with my 8-year-old? And I get so excited because I'm like, oh my gosh, the things that I have seen, like I've seen them get the same video game, and maybe that's the entry point into talking about it. I've seen someone create an amazing Kermit rating scale for foods and things like that. So a lot of really just amazing ways to connect with people. There's a question, I think this is all probably from the same person. Can a fear of becoming gluttonous, is the word that's being used, be a cause or factor for ARFID? What are your thoughts on that, Shira?
I would say someone with ARFID could have that be a fear, yes. But when we think of sort of those maintaining mechanisms for ARFID, like the body image piece isn't one of those like main components. It doesn't mean that a body image piece wouldn't be there for somebody struggling with ARFID. I think just even that word gluttonous makes me definitely kind of lean more towards someone with more anorexia, or bulimia could totally be in there too. But so I'm giving like another really vague answer.
No, I think that's a really good answer, because
yes, but it wouldn't necessarily be like at the cause of it, I guess, is kind of how I'm thinking about it. It might be a part that could be in there.
And for people who are just hearing ARFID, I realize I've broken one of my cardinal rules, which is to use terms without explaining them. So avoid and restrictive food intake disorder, and it can have some different forms. It can be sort of lack of interest in food since birth. It can be a lot of sensory issues. There could be some traumatic event around choking or vomiting. So those all sort of present differently and are treated a little bit differently. And I think it's also worth knowing that ARFID can go into being another eating disorder. So that happens as well, that we see that. And then there are two questions that actually are logistical, but I am glad I have a chance to answer. So Laura was asking, can you please remind me how to access these recorded sessions? I put the equip channel, and it's the playlist is family support group. I put that in the chat. I'll send it out in the letter that's followed up. And then the other question, which gives me a chance to announce something, can you please send this recording or the transcript? We do send the recording out, and we are going to go to a once a month email with the recordings and the resources for just very logistical reasons for the folks that handle this piece of things. I just show up here and do this, and other people make all the other stuff happen. So just want to kind of get folks used to that. So, bookmark that playlist, and we will still post like within a couple days the video from the week, but the actual email with all the links and stuff, we're going to go to a once a month cadence. And then I see that I have some folks with their hands up. I don't know who was first. So Lisa, you're at the top of my list. So I'm going to allow you to talk. Are you there?
Hi, I'm here. Can you hear me okay?
Yeah, we can.
Okay. I think I just had logistical questions because I think I had, JD, you had encouraged me to reach out to the mentor. It's just it's been hard trying to let my daughter manage this because she's 19 and, keeping up with her appointments. She hasn't really been doing, well, she kind of canceled her medical intake. So twice. So she just got that done this last, yesterday, and it's been a month. And my peer mentor, I know they were off last week, I think maybe on a retreat. she got back with me telling me that I was going to be assigned another one. So I really haven't been contacted by anybody. And so do I just wait for that peer mentor to ask all these medical questions that I have? Because on the actual equip side, I'm not able to message any of her team.
Okay, so we might be getting into an area where she might be doing a non-FBT plan, and Mary
Mhm.
know more about that in terms of, but parents should still have a family mentor assigned to them, right?
It sounds like your child may be doing more of an adult path, and there are, I think, some nuances there for someone who is over 18. So it does sound like this may be something that we might want to take offline, JD, just to get into more specifics on how to be helpful.
Yeah.
I think in my question, I had stated, I think she was going to be admitted as a stage 3, maybe. I don't know if that exists, but I think I was told that. But so that's where I felt like maybe it's a little bit more on her own. But as a parent, we're trying to navigate going off to college, and I just have a lot of, concern because we didn't make it through 3 weeks last year. So
Yeah,
that's
I
all.
definitely would. I definitely would reach out to whoever's assigned to you. Hopefully you can access the platform. If not, I would reach back out to the person that you were working with to get onboarded. And if you come to, one of the groups or something, we can also talk, the internal groups, we could talk more specifically. So
Thank you. Thank you guys so much.
all right, thanks. And let's see, Amy, why is that? Well, that's interesting. Amy, I show your hand here, but I don't have the ability to let you talk. So I don't know if maybe your microphone is not on. So I'll kind of just look for that to pop back, and you can send me a message if something's going wrong. Let's see, real quick, because this relates, what does the adult non-FBT path look like at Equip? We're just sort of expanding some things and working on some things. So I'm going to keep it super general, that there's, sort of some other treatment models for other people that can be used instead of FBT. So some things like cognitive behavioral therapy, temperamental based treatment with supports. For individual situations, I would really suggest putting in the request for more information on the form. I don't want to get too much into it because not everything is everywhere. We're in a kind of a transition period. Yeah, so that's kind of as general as I think, or specific as I think I can get. How do you transition a 13-year-old from a residential program to a virtual program? This is what we're considering right now. I'm worried if it is a big jump instead of a more regular step down. So I think that's a really, really good question. I think from my perspective as a parent, and we did not do residential. I think the biggest thing, no matter what happens next, becomes the structure in your home. So even if someone is going to a PHP or an IOP, you've still got them on the weekend, you've still got them at night, generally, all of that sort of thing. So one of the ways we're successful with bringing people straight from the hospital into the program is working with them on why was the hospital working? And generally that answer will be, kind of implementing similar structures at home and things like that. So I think it really depends. Virtual care in and of itself has been shown to be extremely effective. There's really no difference between that and in-person care. I think there's sort of pluses and minuses to each one. What else would you all say about that? Because we definitely get that a lot. We get people coming from residential to virtual, and it works very well. I don't know. What are your thoughts?
Maris, do you want to go? I think one piece that always stands out to me is kind of from an FBT lens, if that is a piece that you do feel very strongly about wanting to really utilize more FBT, just transitioning to home is actually going to likely be the easiest, because it really does put you as the parent fully in charge, whereas with IOP or PHP programs, there's you're not there with them, so there's less parental piece, and there can sometimes be kiddos and that kind of try to pit parents against treatment center staff and like, this is what I get to do there. So it can eliminate some of those pieces. If your schedule makes it really, really hard for you to be able to supervise all meals and snacks, and that's not something that's available to you, then I think, you know, partial programs or IOP programs can be really beneficial, because it gives you that little bit of kind of buffer as your kid gets a little bit more solid in their recovery, and you can kind of figure out who all of your support network and kind of villages at home to support you. So again, definitely there's no one right way to do it.
It does make me think in general. I always, when I talk to parents about whatever their residential PHP program is, it's sort of like, how much are they training you? Like, I really want that to be a component of things wherever someone is, because no matter what, they're coming home to you. And I know for us, where we were at UCSC, I was there 12 hours a week in PHP. And I feel like I needed every single second of what I got there. So then you kind of do know how it's working. Maris, what else would you add about that jump?
Yeah, I never did residential, though I was hospitalized for a period of time. And I know that transition home, my mom describes it similarly to when you go home with a newborn. Like, I can't believe you're letting me just like go home with this person that I'm responsible for, and I don't know what the plan is, and I feel overwhelmed. And that was even with like all the pamphlets and all the discussions before discharge, it's still a really overwhelming experience. So, you know, I would say with a virtual program, you know, hopefully there will be those people that you can talk to and have the plan and debrief after the really hard days where it felt like everything went wrong, and you can learn from it for the next day. So I would say having that source of support around you. And I know that one lesson that my mom felt was really helpful was, just like JD said, really trying to create some really firm structure, at least in the beginning. And my mom actually mirrored it off of, well, this was the meal schedule at the hospital, so let's keep these times for now, just to keep one variable really consistent. So that's what I would offer, is that structure and that community support could be really useful during that time.
Hopefully that's helpful for you. Looks like Amy is ready to talk now. So Amy, you are up.
Of course, my dog just started barking right when you said that. That must have been the hold up.
That's always the way. Zoom is remarkably good at filtering out audio noise, background noise. I have had like bedlam, and people are like, no, I can't hear a thing. So we do not hear your dog.
Okay. My daughter's 21, and I just found out that her state is covered now for the young adult treatment. And I've kind of planted a seed, and I've been working a lot on like connecting before directing and building trust, just basically doing everything you guys say except completely force her out of college. And what else can I say? Like, what will happen if she does that? Like, how does she get assessed? Will she get an assessment like with Equip?
Yeah, definitely. I mean, I don't know every single step of the admissions process, but definitely there'll be an intake call, and you sort of kind of figure things out. Always will need to go to the doctor and get some labs and some other things done, make sure someone's medically safe and all of that sort of thing. So yeah, definitely an assessment is part of it. And then, you know, also goes into, will the insurance cover it, you know, checking on all of those sorts of things as well. And for folks who don't know what Connect Before You Direct is, it's really a way of kind of, before you, not to sort of come in with emotion mind and maybe be like a little escalated. It's getting yourself in the right place to maybe ask questions, to say things calmly, those sorts of things, rather than just sort of like giving directions. And it doesn't always have to be a really big thing. Sometimes Connect Before You Direct is just, I can see this is really tough for you. Like that, it makes sense it's this hard. And this is the thing we have to do. Is she amenable to treatment right now?
She's first, when I brought it up, she was like, oh, I'm not doing that. And then, but because I've been, you know, building her trust, I think she started to get more interested. I just said, well, yeah, you know, I just want to let you know that it's there and that you could call. And, so I just kind of planted the seed, and I just wanted to know if there was anything else you might suggest that I could say about the intake process that might be attractive to her.
Yeah, I mean, it's generally a phone call. I don't think it's, sort of overly cumbersome after the phone call. They're kind of tell her about labs and things like that. You might offer to do it with her. You might offer to stay, sometimes people want that comfort. Any other things that either the two of you would suggest?
This is more of a kind of broader thought, not super tactical to the admissions process, but I know for some folks, there can be this temptation or this almost burden of like, I need to know every single step in order to get started. And I need to have this kind of perfect roadmap of this will happen in my recovery, then this will happen, this will happen. And I know JD and I were kind of messaging back and forth about this week, but so often you just need to know the next immediate step. And if it's taking just the phone call to see what happens, we don't need to say what happens after that. We don't need to know. There doesn't need to be a firm answer at the end of that call, but it doesn't prevent you from just taking that first step of making the call. I don't know, JD or Shira, if you have other thoughts or perspectives on that.
It's funny. I was actually thinking that same piece of like just that first phone call, like just being there to support and say we'll learn, and if it seems like we want to go and see the next step from there, we do it. If not, we don't. Kind of making it that really no pressure piece. So that was kind of where my head was going.
Yeah, and I feel like I know you, Amy, because you've been coming for a long time. I just want to clarify, like, I'm not telling anyone they have to take their kid out of college. That's not my decision. That's not my thing. I do often share my perspective and how we handled things with our daughter. And one piece of my reason for some of the things that we did was that once she was fully financially supportive with a college degree, if the eating disorder was still really in control, we would be pretty locked out of helping her if the eating disorder was very strong. So that was a piece of our equation, and absolutely everyone knows their family best. So I hope all that information is helpful, Amy.
Yeah, thanks.
Good luck.
Thanks.
Let's see. Well, no more open questions in there, so we definitely have time for more if folks want to weigh in. And I'm going to go to the submission questions. And this is a really good question. In some ways, Lisa would like to talk, so we're going to let that go now. Hey there, Lisa.
Hi, can you hear me?
Yeah, we can.
So I'm going to try not to get upset. I'm very new to this.
I'm so sorry. And we all understand if you cry. We've all cried many, many tears over this, so don't feel bad.
Okay. So my daughter's 16 and 4 months in, and it's been very difficult. We did get into eating disorder LA with Dr. Molheim doing FTB.
FTT.
And unfortunately it's not work. It didn't work. She's very strong-minded and it's just getting worse. I did. She finally agreed to one-on-one therapy. So she had her first appointment this week, which was lovely. And then she's seeing a dietitian next week. We have Kaiser, so we're going through that system. I did set up, I reached out to a treatment program, Center for Discovery. We live up in the South Bay of Los Angeles. And I've befriended an admissions officer there who actually my daughter has talked to, she's also become friendly with, but she's refused to go do treatment in there at this point, which is very frustrating. I don't even know where to begin with questions. It's the eating. It's so hard. And now it's getting worse. So many fear foods.
Yeah.
And supplementing with, Ensure shakes and adding stuff to it. Now she won't even drink the Ensure shake. Her labs are actually okay right now, but they're on the lower end. But it's affecting the heart, you know, it's getting low. So the malnutrition is hitting that. She's still at an okay weight, you know, okay in quote marks, right?
Yeah.
You know, she's at 136 right now. She's probably lost about 30 pounds since March. That's when this all started. So it's the battle of, I look good, you know, I like how I look. And then it's all these fear foods and just, you know, when my husband and I try and get her to eat.
Yeah. Well,
The
first of all,
anxiety.
sorry.
Go ahead, sorry.
Yeah, the anxiety you're talking about. Sorry, it had cut out for a second, so I thought you were done. But certainly I think everybody listening who's had a kid at any stage of this can really relate to everything that you're saying about this and how hard it is. You know, some of the threads I'm going to pull on would be sort of number one, that really strong will.
Yeah.
That is a universal requirement to have anorexia. Very interesting. Anorexia is positively correlated with high intelligence, with a very strong will, with
Yeah.
sort of doing things for one's own purpose versus what everybody else is telling you to do. So a lot of those things. Certainly working with Dr. Mulheim. We love Dr. Mulheim. Wonderful, just wonderful clinician, really good friend of mine. I will tell you a little bit about what I learned with doing FBT with my 17-year-old, which was, I did think I had tried everything. And sort of the one thing that I hadn't tried was sort of making it very non-negotiable in terms of there will be no phone, there will be no school, there will be no, you know, at the same time as I was doing meal coaching skills and sort of things like that. Sounds like you're in California. One of the
Yeah.
things I like about California is we have a lot more, without saying authoritarian, without seeming authoritarian, because I'm not, we actually have a lot more authority over our kids in the state of California to the age of 18 than some other states do. So like Wisconsin, for example, at 13, they can make their own mental health decisions. Washington State, you have to jump through a lot more hoops to be able to sort of make decisions for your children. So I'm happy. I was very happy to be in California with a 17-and-a-half-year-old.
Well, question for you though on that. I was told since she was 16 that she can refuse to be into a program and they won't accept her. They won't do it until
those are the programs saying that, not the state of California law. So I've had someone in a program in the state of California who did not have to consent to treatment. So that's, without getting too much into the weeds of like, and I'm also going to really encourage, if you're not on the feast around the dinner table board on Facebook, like that's going to be a really good source of information for you as well. That said, I also think that consent comes in many like forms, and grudging consent is just as good as you know, sort of like full-throated, full-hearted consent as well sometimes. And you know, I'm hearing, and you know, I empirically, if someone's lost that amount of weight and it's beginning to affect their labs and heart, like what the weight is on a BMI chart doesn't mean anything to anybody. It's and very often people who start at a slightly higher weight are much sicker because of just what you've said. And very often doctors are going, oh, that's great, you lost 10 pounds, that's wonderful, you know, and people don't notice it until it gets sort of really, really scary. I'm a big one for like not waiting to stage 4 to treat something that I could intervene in on stage 1. So I'm wondering if maybe, you know, sounds like you have a partner, you have a husband. It might be super helpful. The Men of Feast group is really good. You know, him getting in there, you getting some other support on what other people have done in these situations. And overarchingly, and then I want Sharon Maris to weigh in from their point of view, but overarchingly, I have a really strong opinion that it's not really generally the best path to let a mentally ill teen like drive their treatment decisions, if that makes sense.
Oh, that makes she's trying to do that. She thinks she's in charge, and it's a
Yeah,
constant battle every
yeah.
day. And it's
Generally,
get ugly.
yeah, and I will, just to right size before Shira and Maris, come into this, right size the ugliness of this. I mean, ugly is a very, very, very good word. What I thought about was that my daughter was being asked to eat a plate of snakes and spiders 6 times a day. And so within that context, her really extreme reactions and emotion dysregulation made a lot of sense. So I needed to develop some strategies. Dialectical behavioral therapy, very good for that. Support from other people who had a kid with an eating disorder. People had gone behind me, before me, super helpful. Some of it was situational, like serving food on paper plates so that if it got thrown, I had another backup, things like that. Learning what was important to her, school being one of those things, right? And so some of it is just sort of figuring out what it is that they want more than they want to keep the eating disorder. And I also hear you say things are getting worse and worse, which is what happens, right? The longer the malnutrition, the lower the weight, whether or not it looks good on a chart or not, that is what happens. And so, it sounds like ultimately your next step would be, sort of the hospital, and there's sort of no, if that happens, right? Your 60-year-olds aren't allowed to refuse going into the hospital when their heart rate is too low or things like that. And sometimes it's a good time to do like a real reset and get your ducks in a row at home as well and sort of figure out things. But in terms of it being super, super ugly and miserable, like it is, one of the great things about multifamily groups is when you think, oh, surely my child is the only person who's throwing things and dropping F-bombs and running out the door. And then all of a sudden, like 6 other people are like, oh, your kid does that too, right? And I'm making light of it, but those are actually super, super common. Maris and Shira, what would you sort of add to that from your perspectives?
Yeah, I can add that I can imagine if this had existed at the time, my parents coming on here to ask the same thing. Like, what can we do? We just feel powerless here. And I know when I was first diagnosed, my parents really and truly thought like, Maris is a smart girl. We'll sit her down, we'll explain the medical consequences of this whole thing, and she'll realize it's ridiculous and just stop the whole mess. And it was so topsy-turvy for them to wrap their minds around the fact that I was not going to say, I'm sick and I want to get better. That just wasn't where I was, and that just wasn't how the eating disorder operated. So me personally, I would not have raised my hand, at least at the time, and said, I want treatment. My parents made treatment a non-negotiable for me. And I would not have said it at the time. I now think it saved my life. I'm extremely grateful for it. I also went literally kicking and screaming. So I think we can look for opportunities to be compassionate and warm and validating along through that process and make it as safe as possible. It's also just an incredibly difficult thing. And I think most people, for very good reason, don't want to sign up for something as hard and painful and difficult as eating disorder treatment, especially someone who might be that sick. But I'm curious what you think, Shira.
Yeah, I just absolutely echo what you both have said, and just how tough it is as a parent being in that position. And yeah, it is unlikely that she's going to be able to fully recognize everything that's going on, regardless of where someone's weight started was or whatever. I mean, losing a significant amount of weight really does put the brain in a spot of, and when you're not nourishing it regularly, of not being able to process and understand everything, and those non-negotiables. And sometimes that non-negotiable is just that I'm physically picking you up, putting you in the car, and we're driving to wherever treatment is. Again, I worked in residential, and there were definitely people that their parents would come in and be like, our kid's out in the car refusing to come in. It's like, okay, like we'll work with that. So I think too, knowing that if going into a higher level of care is what ends up happening for you all, like she does, like Mara said, she does not have to be like running in there saying, yay, thank goodness I'm getting treatment. And wherever, which you're probably like, I can't even imagine that happening right now. That's the most far-fetched thing ever. But that treatment center is well used to those situations, and it won't be alarmed, will be calm and totally be able to support both you and your child. So if that can help you kind of rest easy. And I think what JD said too, of that piece of like sometimes needing to, you don't want it to get to a medically unstable place, but sometimes that does give you the space to be like, okay, how are we regrouping? I think I said it before, like getting that community and your support in place of like, what are we doing? How are we going to shift this? Because it's such a learning process too. Like every single thing is just like, oh, this one didn't work. We need to try something different. And like, all right, let's stick with this for a little bit.
I mean, but there's times where it's like, you know, if she gets hospitalized, because it's getting close. Yeah. And she will not do what she needs to do.
Yeah. And I think, oh, sorry, go ahead, Shira.
I was just going to add the other piece that I don't think any of us have mentioned is that idea of like making that comparison to more like medical diagnoses where, and I don't do this all the time, but like thinking about the diabetes, like analogy, like if your child wasn't taking their insulin, like you would be doing things to make sure they are taking their insulin, and like your child's not eating, you're going to do things to make sure that they're eating, and that's well within your scope as a parent.
Yeah.
So sometimes I think for parents, it can help kind of take that worry of like, am I doing the right thing? Am I not? They don't want this, like out of it a little bit, and give you that confidence.
And I'm going to add to that, Lisa, that when I came into this was the youngest of my 4 kids, and I was an educator. I believed in positive reinforcement. I was not an authoritarian parent. I had a very, very independent, child in this. And it was very hard for me, and it is for many modern parents, to wrap their minds around sort of like taking control as much as I did. So my 17-year-old, in order to help her, had to be treated like a 2-year-old trying to run away from me in the parking lot. In our case, and this doesn't, I always want to caveat this with saying this really depends on your demographics, where you live, how your local law enforcement is, things like that. Part of our journey actually involved that the police might be called, that there might be a psychiatric hold, that there might be, sort of things like that. So all of those are really, really hard to think about. And also what I found, that once you talk to other people who've done them, or once you've sort of done it yourself, it demystifies it a little bit. And the ultimate thing is, like, this is an illness that's so cruel because the person absolutely does not want to get well. This is why most people don't. And so this is why, sort of FBT was something that really moved the needle in terms of like taking the healthy people in the home and tasking them with this before, asking for buy-in or things like that. And one of the other things with FBT that we like jokingly call it food before therapy. And, Shira made that point so well. Eating disorder aside, at this point with her brain the way it is, that there's not a lot of really good thinking and processing going on. Right. I also popped in the webinar chat, so you can open these up before we leave. And thanks, Krista, for putting the Feast face group in. It's a closed group. You'll find, post your situation, find lots of people. You'll find people who live in your area with Kaiser. You'll find, because I know some of those stories that I can think over there. And then also I put in a link to Minna Feast, which is the group itself is wonderful. And also there's a series of videos that have been done by Kevin Dunn, who is our director of family mentorship, and also very heavily involved in Feast. And these are very short, very skill-oriented videos. Because one of the things that I didn't have success when I was just sort of like running around with the chicken with my head cut off, trying to make things happen, right? I had success when I finally was given some skills. Because nobody has a skill set right now. And Kevin has come up with a really great analogy that I like a lot, is that our family's operating software is 1.0. We need the upgraded version that includes how to parent a child with an eating disorder, and that doesn't come with the original package. And so that's sort of what we're doing there. So I think I want to give you some hope that with, you know, some more information, some more support around you, some more skills building, that these are things that really are possible for you to accomplish.
All right. Thanks, ladies.
All right, thank you. And then Amy, your hand is still up, so I don't know if that means you want to talk again or if it just didn't get put down. Oh, there it went. Okay. Question, is there a specific BMI or percent of ideal body weight that is required to be accepted into EQUIP? Just generally in all outpatient programs and a lot of residential programs, there is some sort of minimum, which is usually 75% or 80% ideal body weight or of median BMI expected for age. Different programs will have sort of different ways that they calculate it. And that's, again, to really want to make sure that people are medically well enough to be able to be in an outpatient program. Shira, is there anything else that you have seen around that, or does that jive with what you?
Yeah, I don't necessarily, and I'll be super honest, I don't know what EQUIP uses for things, but in general, there are some kind of cutoffs, and it really is the medical stability piece is where it can get.
And I will say we are our doors open as wide as it safely can be. So I will say that about that. So definitely worth, you know, putting in a forum, talking to folks, you know, when things are like real need, everybody has to get medically cleared, right? And if that's in doubt, that gets the medical clearances with a magnifying glass, right? So there's a lot of things to go into that. So we want to make sure everybody is safe and gets the help that they need. Well, that works out pretty well. We're just about out of time, and that was our last question. So thanks so much to folks for being with us today. Again, super excited next week to have Kevin Olmsted, who wrote the book Brave Dad Feeding, which I thought I had at my hands, but I don't, which is really an interesting account of a father learning what he needed to do with FBT and how that all worked. And so we're looking forward to talking to him next week as well. So Sharon Maris, always happy to have you, and we will see folks next week.
So much. Take care.